Welcome to this very special event, part of the USC Institute on Inequalities in Global Health virtual lecture series. My name is Sophia Greskin, and as director of the Institute, and on behalf also of the USC Law and Global Health Collaboration, it's my great privilege to welcome you to this conversation on self-care interventions for health and well-being. We're delighted to have our close colleague from WHO with us, as much as our wonderful colleagues from around the university. At IIGH, we've been working at the intersection of self-care technologies, law, and rights for the last few years, both within USC and also outside, with partners in several countries and also at the global level. It's an important area for us in that self-care interventions can, when they're optimally designed and implemented, increase access for hard-to-reach populations, improve quality of life for people who would go otherwise without care, and maybe more importantly, increase privacy and autonomy. But there's also concern that these sorts of technologies can also result in violations of human rights and inadvertently increase inequalities. And in all cases, in particular, for the most vulnerable and isolated populations in the US and around the world. And it's these sorts of issues that have moved self-care so centrally onto our agenda at IIGH, and why I'm so very glad that this event is happening. And with that, I would be very happy to introduce my friend and colleague, Laura Ferguson, who is the Institute's Director of Research and of our program on global health and human rights, and the lead for much of our work around self-care. And with that, Laura, can I turn it over to you to introduce the event and our distinguished speaker?
Of course, thank you, Sophia, and let me add my welcome to all of you. It's great to have you all with us. So just in terms of the event itself, I'll introduce our main speaker now, who'll then take the floor, after which I'll introduce, we have two discussants and ask each of them to respond to Manjulaa's remarks, and then we'll open up to a Q&A with everyone. So please use the Q&A function to submit questions, and we'll get to as many of them as we can at the end. So our speaker today is Manjulaa Narasimhan. She is a scientist at the Department of Sexual and Reproductive Health Research at the World Health Organization in Geneva, Switzerland. And a few years ago, she noticed a vast increase in the use of self-care interventions around the world and a lack of normative guidance for how they might best be provided. Now, traditionally, WHO's guidelines are clinical. They cover what should happen in health facilities. But when you think about self-care interventions, they're often used outside of those settings, which meant that a truly innovative guideline was needed, one that considered the whole environment within which people use self-care interventions. So beyond the biomedical, it had to also address human rights, gender, access to quality information, strong linkages to health services, and so much more. So it's been a journey. Manjulaa had that vision, and she led the whole process of guideline development, not once, but twice, with the original guideline published in 2019 and an updated version last year. It's an absolute honor to have her with us, and a great pleasure to introduce my colleague and friend, Manjulaa Narasimhan. Manjulaa, please.
Thank you so much, Laura and Sophia. I think this is really an honor for me to be here. I'm really delighted to be part of this lecture series that you have, and to give an overview and some thoughts about the guideline on self-care interventions for health and well-being. And I will see whether I can share my slides and start. Self-care is not a new concept, and it's quite an odd topic to be presenting, because while we may all call it by a different name, you and I are all sort of practicing some form of self-care. And so that what I'll aim to answer here, sort of three questions. So what is it we're talking about? What kind of terminologies, what do we mean by self-care or self-care interventions? Why is it important? And, why is WHO involved in this at all? And, why did we develop these guidelines? So I'm just going to focus on those aspects. And as Laura said, it's been very complex. It's been quite a very interesting journey. So let's just maybe start with what it is. What do we mean by self-care and what we mean by self-care interventions? So that the terminology that we have used, and this is really based on a review that we did of documents and papers that from 1950s to now, covers so the ability of individuals, families, communities to promote their own health, prevent disease, maintain health, cope with illness and disability that can be with or without the support of a health worker. And it really recognizes individuals as active agents in managing their own health. And in areas that include, as it said here, health promotion, disease prevention and control, self-medication, self-treatment, and also providing care to people, as caregiving roles as well. So we have differentiated in the guideline and in our understanding self-care written more broadly like this to self-care interventions. And the guidelines are actually on self-care interventions, which we are defining as tools that can support self-care. So, and there are different names. So we have, for instance, self-administration of injectable contraception, or HIV self-testing, or self-management of medical abortion. And there are very many terms. Not all of them are on the slide, but it's really to show you the range of terms that could be used around self-care, both from a health system perspective, but from an individual or community perspective as well. And some of these would need more engagement with the health system, some perhaps less. So there's, it's very context specific and intervention specific as well. And the term self-care interventions we're just using here broadly for all of these tools, whether they're information devices, diagnostics, products, to support a person's ability to self-care. And one of the reasons we ended up creating a classification of self-care interventions was because there was such a range of terminology out there. And these are all living documents. So we hope if you have feedback on any of these documents that you could send it so that we can continue to have a dialogue and support efficient and supportive interventions for individuals. So this classification document is really for researchers, for policymakers, for donors and others working in this field to try and have some bridging language. And so the way it's been set up is we've got interventions for self-care interventions that people can do, and enabling actions by different cadre of health system support, which could be from health workers themselves, health program managers, policymakers, legislators, regulators. And the way this has been set up is in sort of simplified tables so we could see some of the linkages from a challenge that the health system or a person can be facing to how we could address that challenge through self-care interventions. And the document therefore has a series of health system challenges, the type of interventions, where some of these interventions could be accessed, and what some of those improvements can be from at a health system, but also at an individual level. So as just one example here, in terms of the lack of facility-based health services that are available for more than half of the world's population. If we start from the health system challenge of the lack of accessible health facilities and the individual need for being able to access a quality care or a facility or an intervention, what could be some of those interventions that we would need? For instance, an HIV self-test, that you could do when you're not able to access, you've been at, perhaps at risk of HIV, but you can't access a facility. If you have an access to an HIV self-test kit, you may be able to get the results faster, in your own time, and take it in a space that you feel comfortable with. And of course, if the result is positive, you will still need to go back into a health facility. So this is not to replace health systems at all, but to give people additional options and additional choice. And so this classification talks about where some of these interventions can be accessed. And here, there's just some examples here in terms of over-the-counter availability at pharmacies. And the overall goal here is to sort of improve health outcomes. And we just did a recent webinar on this, so I just put the links just for, there were a lot of really good examples from different settings in terms of how self-care interventions and links to the challenges and how it could be addressed are explained. So very quickly, in terms of why are self-care interventions important, and how they can contribute to perhaps achieving global health goals. From WHO's perspective, and you are probably familiar with this, we have this triple billion target. So 1 billion more people benefiting from universal health coverage, 1 billion more people enjoying better health and well-being, 1 billion more people better protected from health emergencies. And self-care options can contribute to all three of these goals. So in terms of empowering individuals, families, and communities to advocate for their own health, and in meeting people where they need to be met, and providing them with comprehensive integrated care across their life course. Because we know people dip in and out of health services. It's not just at one time that we need to provide them with these options, but across their life course, and to provide it with evidence-based policies and actions. So it's not the interventions that they get, the products that they receive, the information that they received are not only evidence-based, but they're quality. And so we're not supporting actions that could perhaps cause harm, but that are really supportive of the needs of individuals and of the health services as well. Self-care interventions can also support strategies for health promotion. And here there's just a couple of many organizations have these tips to be healthy, eat a healthy diet, be physically active. And on average, we estimate that for the 1 hour that we may spend with a health worker or in a facility, there's just so many more hours that people on average can spend on their own self-care. And this is data from the UK, but we're seeing this similar scenario elsewhere. And so self-care interventions, again, has the potential to promote individual participation in healthcare. And here as an example, inactivity and reducing tobacco use can prevent cardiovascular disease. It's just one example here, but we know that there are many others. And self-care interventions, the third triple billion target here, can support responses during health emergencies. And again, we know that there are 130 million people who are in need of assistance from various humanitarian crises. And unfortunately, this number is now increasing. I'm based in Switzerland, and we are very close to where the Ukrainian crisis is happening. And sadly, we don't seem to learn from past war scenarios. So the provision of tailored and timely self-care options to these communities who are fleeing conflict or even in conflict should really, from WHO recommendation, be part of emergency preparedness plans and providing for ongoing responses. And of course, one a pandemic that is still ongoing is the COVID pandemic. And when we developed the first guideline that Laura mentioned in 2019, we knew that self-care was going to be important. And then COVID hit. And of course, the role of individuals and of laypersons in managing their health has just never been more, I think, more present, at least from the health system, from the health system perspective. And so this is one of the reasons we increased the scope of the guideline, and we rapidly looked at the evidence and released a second guideline in 2021. And again, here, this is just to show, this is an older slide, but just to show that with an estimated global shortage of health workers that we know was already there pre-COVID, with the COVID response, with the projected COVID response that will continue to go, with the additional humanitarian crises that are happening, we are going to need to find alternative solutions to simply a health system focused approach to healthcare. And self-care interventions really offers some of those additional options that we can give, not only for individuals and laypersons, but also for health workers themselves, given the high rates of burnout that we're seeing, and for their own emotional resilience and well-being. And again, this is an older slide, but we know that a lot of the self-care health facilities have been disrupted, and self-care options have been prioritized in a lot of these settings, where individuals have been able to go either through a pharmacy or being able to do some of these interventions at home in order to not put themselves at risk by going into facilities. And one example is, for instance, pregnant women who could monitor their own blood pressure at home. They would still need to have antenatal care visits if they're at risk of preeclampsia, but they also have the option of being at home if they can't access a hospital in wherever their sitting is. So people have been practicing self-care during COVID, as I mentioned already, going to pharmacies and drugstore, health providers being able to provide from a distance, community health workers being connected to individuals who are at home during lockdown. And of course, the digital health technologies have, the use of digital health technologies has increased dramatically to link individuals to healthcare. But as with all healthcare, attention to gender and human rights remains central. And not everyone will be able to access quality interventions. Not everyone can understand their right to be able to access a service or a product. And for many people, they may need to be away from their home altogether. And so practicing self-care may not be an option at all. For instance, women who are subject to intimate partner violence or other forms of violence, who may need a shelter, be away from home, or in another closed setting, such as people who are in an old age home or in refugee camps or others. And then there are people who may be experiencing homelessness, or migrants and displaced populations who have a lack of neither. They don't have access to options that they can use on their own. They may not have options to go to a health facility. So we're really mindful that yes, this is something that can increase health coverage. It has a lot of potential, but really to be mindful that we're not adding burden to individuals, and particularly the marginalized, the criminalized, the vulnerable members of our communities, of both individuals, but also some populations. So with that in mind, some of the key principles that we had to inform the development of the guideline, just to say that the target audience of the guideline, as with most WHO guidance, is primarily for policymakers, ministries of health, program managers. But this guideline, we've extended that further to ensure that civil societies have a voice, and then even product developers and the persons affected themselves, and avail of some of the recommendations and the good practice statements that we've developed. And the focus of the guideline includes interventions that are in transition. So we've not looked at recommendations that are already there. So we've included those recommendations. We haven't focused on things that we know already work, such as condoms. There's not a new recommendation on condoms use, for instance. But we've initially focused on interventions that normally would have been provided in a facility, but that over time can be used or be uniquely provided, can be used by an individual. And we know that some of these interventions are not new. And as I mentioned earlier, some of the more underserved members of individuals and communities will require more support. The approach we've taken for this guideline is a people-centered approach. So it's about putting individuals' needs at the center and ensuring that they have equitable access, that they are able to access it when they want across their life course, that it is done in a way that's respectful of people's dignity and their social circumstances and the cultural norms. And we'll get to the fact, that to be endowed with the rights and responsibilities that people can exercise and avail of these options. And there is this shared accountability that is important here, not only from the health worker and the individual, but from the health system as a whole. And this again, it's not about washing our hands of the responsibility of simply providing a quality intervention or a product and then saying, well, it's on you now. And of course, there'll be ethical considerations that we would need to take into account, and looking the opportunity here to look at the holistic needs of the physical, the socioeconomic, mental, emotional well-being of individuals. So with that in mind, the conceptual framework that was developed to inform the guideline has that people-centered approach. So it's really about moving away from a disease perspective. So it's not about eliminating a disease, but really about improving health and well-being. So, how do we produce health rather than eliminate a disease? So it's about investing in the principles and the enabling environment that can allow for it's a sustainable long-term change in healthcare delivery. And so some of the key principles are noted here: human rights, gender equality, the life course that I mentioned earlier, and a holistic approach to health and ethical considerations. We acknowledge that people access health interventions and information outside of traditional health facilities. So the health facilities will continue to be important, but digital platforms, over-the-counter at pharmacies, and other means of access for health information and technologies is becoming increasingly important. And for all of these interventions, that safe and supportive enabling environment and the elements are, some of the elements are included here. And we're aware that not all of this is available everywhere. This is an ideal sort of scenario, but it needs to be spelt out so that at least it can be, we can work towards achieving it. And the accountability of donors and the government and the health sector remains important throughout. So just very quickly, in terms of the development of this guideline, one of the first meetings we held, and Laura was key in that meeting, was about ethical, legal, human rights, social accountability implications. And we started off with that in mind. And there's been a whole series of consultations, including on economic and financing considerations, hearing the voices of the end user, through a global values and preferences survey, both from health workers, but from users from different contexts, and focus group discussions with particularly the vulnerable population that has informed some of these, some of the recommendations and the good practice statements. And for the human rights considerations to, the right to the highest attainable standard of health, informed participation, non-discrimination, the right to seek and receive information, to get to that informed decision-making in terms of health, the privacy, the confidentiality, the accountability, all of these, and some of the other considerations on the legal policy, the regulatory environment, were considered and were part of a human rights framework that was developed with Laura, Sophia, and colleagues at USC. And out of that literature review, out of the discussions we had at the guideline development group, a range of sort of good practice statements on self-care interventions and what would be needed to support human rights and gender equality were developed. And this is key to how the recommendations will be rolled out. So I'm not going to read all this, but it's there, and it's really some of the foundation of how we hope that countries will roll out the guideline. And based upon that, some of the recommendations that we have, and here I'm just focusing on recommendations around sexual and reproductive health and rights, which is where we initially started this work. So just as an example, self-management of medical abortion, HPV self-sampling for improved cervical cancer screening, self-administration of injectable contraception to reduce unintended pregnancy, and many other interventions. So the biomedical interventions that we know is safe, that we know can be cost effective, and that we know that people can use it on their own. So we do have recommendations around this. But again, as I mentioned, those elements of those enabling environment of human rights, the gender equality, all of those considerations that particularly for people who might fall through the cracks or who we are not able to reach, all of those elements are really going to be critical in order for this to make these interventions to make a difference. I have included here some resources, and we can come back to this, and I'm happy to share this separately afterwards. And I think I'm going to stop there. And I guess, when we invest in people's autonomy, their agency, their ability to make decisions that can improve their health, but their well-being, this is an investment that it is well beyond, the UHC, the PHC, the SDGs, all of these targets that we set. This is something that can, I think, go well beyond health, because we are improving lives of individuals and their communities. So it's thus far been an sort of an undervalued and underused potential of healthcare delivery, but hopefully this is something that will change the way we see care being delivered in the future. So thank you very much. It's been a great opportunity to share some of our thoughts from the WHO perspective on the guideline and our work. Thank you.
Thank you so much, Manjulaa. That was fabulous, a really comprehensive overview of some of the work that you've been doing, and great to get those insights. So what I'm going to do now is turn to our discussants, so for their reactions to that. I will remind the audience, please continue to use the Q&A function, so we will come to that afterwards. But first of all, it's a huge pleasure to introduce Peter Redfield, who's a Buru Chair in Ethics, Globalization and Development and Professor of Anthropology here at Dornsife. He's also on the steering group of the Law and Global Health Collaboration and has been involved in a lot of our work around self-care within USC. So Peter, let me turn to you first for your comments, if that's okay.
Yes, of course. Thank you, Laura, and thank you, Manjulaa, for this very interesting presentation. I will try to be quick and just flag a few things so that there can be other discussion and with questions and commentary. The first thing I would note whenever thinking about the self and self-care is that humans, of course, are relational beings. And I was reminded of that as I was trying to get to campus this morning through LA traffic, that our lives are not only under our own control, but also we have to respond to the things that the world presents to us. And much of that involves relations with others. And so when I listened to this extremely interesting effort and the framework being proposed for principles, all of which sounds most valuable in terms of thinking about global health, I'm also reminded of the history of the long, many efforts to try and extend healthcare beyond the framework of clinics and hospitals globally. I'm thinking about the famous work Where There Is No Doctor, for example, community health workers, the barefoot doctors movement in the People's Republic of China and beyond internationally, that there's a long history of trying to compensate for inequality of access to formal service delivery in biomedicine. I was also quite interested to see what conditions, particularly the framework flags and emphasizes in thinking about where self-care might be more appropriate. In that one of the things I learned from looking at humanitarian medicine for a period of time is just how many things can go wrong with humans, both individually and then in populations. There are all kinds of different problems that can present themselves. And of course, self-care is appropriate for people who have the capacity to care for themselves, whose problems do not render them unconscious or render them in some way other incapable of responding to whatever the issue might be. And I was thinking that there's some parallels actually between the self of self-care and the self of the legal person, the one who can represent oneself legally in a setting, the bearer of rights, the one who does not need a guardian or does not need a representative, but rather assumed to have that capacity. So assumed to be an adult without any sorts of impairments which might prevent that capacity to represent or to care. And the last thing which I wanted to note, because it struck me as being the critical question when it comes to self and self-care, which I think is present in these guidelines, and I just want to draw it to the surface and emphasize it, is the tension between the possibility of self-care as being a form of empowerment, of enabling people to do things, versus the prospect of self-care as abandonment, that there is no one else to care for you. Just going back to recalling that humans are relational beings and that we come into this world, we're cared for, we only exist, all of us here, because others cared for us when we were very small, that our lives are a constant, continuous negotiation of care. And it can be very empowering to care for yourself, but it can also be an experience of isolation or abandonment. And it seems to me that is a critical tension to be thinking about in relation to this concept as applied more broadly throughout the world following these guidelines. So thank you again for this extremely interesting and important intervention.
Thank you so much, Peter, for raising some really key issues there. And I think, you know, your question of empowerment versus abandonment is at the center of this. And I think it's one of those questions that's particularly nuanced by who the self is in that and where the self is in that. And so I think that there's some good discussion to be had about that. Manjulaa, before I give you a chance to respond to any of this, I would like to introduce our next discussant, Yaniv Bar-Cohen. He is Professor of Clinical Pediatrics and Medicine here at the Keck School of Medicine, and he works as a pediatric cardiologist at Children's Hospital Los Angeles. He's also the co-director of the West Coast Consortium for Technology and Innovation in Pediatrics, so brings a very different perspective again on all of this. Yaniv, the floor is yours.
Great, thank you. So first of all, I want to say that that was an excellent talk, and self-care is such a, in some ways, confusing word, but it's just a broad concept. It's sort of always been with human beings, but what's so important about these guidelines is an effort to build a framework around this issue, define some of this issue, I think is very, very important because it helps us target the best ways to use self-care for whatever you're trying to accomplish. And I do think there's a goal of helping marginalized communities, and that is a very different goal than how self-care is often used, especially in sort of my line of work where I think about technologies. And so I sort of have two important ways I'm thinking about sort of how we have to think about these issues from the perspective of someone who lives in technologies and lives in pediatrics. So everything I say is kind of skewed by that. So first of all, in terms of building technologies around self-care, it is very, very important to, in fact, focus on the fact that you're doing so for marginalized communities. And that's why I like these guidelines and why this really is a conversation about inequities. Because what I've seen in people trying to digitize, to try to develop digital technologies is there's a whole lot of focus on, excuse me, how to monetize everything. And so many of the technologies I see people try to build work on even something as simple as, well, here's a smartphone app. And, you know, smartphones have an immense role in self-care, especially self-care to marginalized populations, because a surprising number of people, even those with very limited access, still have access to smartphones. And smartphones, one, have the ability to educate people in ways that we've never been able to do before. You can build devices that can interact with the smartphone. That allows you to track information about patients, allows you to communicate with other aspects of healthcare. All that is available through the smartphone. And some of these things like apps, we think of as like, you know, it's a 99-cent app, or it's free, or it's limited cost. But the reality is when we develop these costs, at least in the United States and in the groups I've worked with, there is definitely a huge focus on how to monetize them. And one has to be incredibly intentional with these digital technologies around not focusing on monetizing them and focusing on marginalized populations instead, because it can absolutely be done. It can help in so many ways around inequalities. The other focus that I think of, and this is my pediatric skew, so much of self-care, I think in the guidelines and in general, the focus has been around sexual and reproductive health. And the reality is that sexual and especially reproductive health targets a certain age group. That's a big age group, but it's kind of in the middle. And so much of healthcare and disease is at the outskirts in pediatrics and the elderly. And a big part of the problem of focusing on patients who don't have access is how do you access those patients who don't have access? And all that is education. And targeting sexual health, reproductive education is a very different age focus than diseases, which are on the other side of the spectrum. And that's a challenge, and one that I assume people continue to work with. It's one thing to have these guidelines and say these are all the right things and how we should move forward, but how do you actually tell the people who can most benefit from it? So anyway, those are my comments. And again, this was a great talk, and just the ability to even begin to put a framework around self-care is so important, and you've done a great job of already advancing that quite a bit.
Thank you, Yaniv, again for raising a different set of issues, but equally important and equally valuable for moving forward the discussion, I think. So before I get to Q&A, Manjulaa, I would like to turn back to you to see if you would like to pick up on any of the points that Peter and Yaniv have raised and take any of them a little further. So I'll pass on to you, Manjulaa.
Okay. Yes, there we go. So thank you so much for that. And no, it's great to hear. I'm just going to see where do I start. So let me start with the link between the digital health and self-care. That is one that we have been grappling with for some time. And one of the areas of work, which I didn't present, but that's happening not with also with other colleagues in WHO are the development of smart guidelines. So how do we digitize some of these guidelines so that it's available for countries, and it's available through apps that the countries can adapt for themselves, but that are evidence-based. So it is something that's also happening, and also for self-care. And we really recognize, and there's a whole guideline that's being developed for telemedicine, for instance, so that how can what might be some of those linkages for a person-centered care, and linked through digital systems and digital platforms with health systems. So there is work happening there. But what you're absolutely right, the issue of monetizing some of these technologies, and again, the lack of access to data that people can understand, and that they know is trustworthy, is two separate things. I think with COVID, even with my own family, I keep getting questions. Everybody's checked some. Everyone's become a Googleist, so everyone checks, and everybody knows something before they go to see the doctor, or they know. And then they've got all these questions that are inaccurate, or and just false information circulating. And so I think there's and some people, I mean, there's also this feeling that if I pay for it, then it's going to be accurate, that it's going to be okay. And so there are certain risks that I think we do need to tackle in using the opportunity that smartphones and these new technologies are going to provide, and then really being careful that we don't fall into traps there, and particularly the people who don't quite know where to look and where to get that data. So it's a good point. I don't have any answers to it, but it is something that we're going to need to tackle at some point. And then just very quickly also, yes, we did start with sexual and reproductive health and rights, because, well, I sit in that department. So it was also from that perspective. But in the 2021 guideline, we have expanded that scope to include NCD focus, and we hope that this can continue to expand. We're working closely with colleagues in child and adolescent health, actually, on home-based records and the use of digital home-based records, or just home-based records that can help mothers and children monitor health in settings where so there are certain pieces that are happening, but we absolutely need to expand. When we talk about, I mentioned several times that we need to have self-care interventions across the life course. We currently have recommendations for a certain period of the life course, but not across the life course, and particularly for elderly people. And by elderly, I think it's everybody above 50, so that includes me. It's just like there's no data, like there's even very little data. So because the recommendations have to be focused very much on, evidence, we are often caught in this situation where even when we know something is important, where we need to have that research done, we need to have those publications and so that we can develop those recommendations from WHO on the latest evidence and the best evidence available. And often for certain populations, and I'm not saying for children that's the case, but for some of the older populations, for instance, there is not enough data on some of these areas. But this is something we are hoping that to increase also research, so that we can, when we revisit this, because it is a living guideline document, when we revisit it, that we can continue to build upon it. And so I'm just going to also come back to Peter, what you were saying. Yeah, absolutely, the self-care is not new. There's been many attempts to try and reach some of people who have lack of access, or who are far away, or in villages, and there's mixed responses. It's not always been not always been successful. But the issue, the tension between when you said enabling and the abandonment, I absolutely hear you. And one of the most interesting conversations we had during the guideline development group, and Laura was there, so she can weigh in, is the use of gender affirming hormones for transgender individuals. As just one example, where for many examples is, yes, it can be empowering, and we want them to have additional option. And a lot of young women, and they wanted self-administered injectable contraceptives as an additional choice, that they thought that was great. But for transgender individuals who are often forced to do self-care because the health system, they're facing violence and stigma and discrimination, coercion within health facilities and in their communities, and they're obliged to I'm not sure we can call it self-care at all, but they're obliged to care for themselves in a way that is not supported. So it is definitely a tension that we need to again make sure that what we say is based on evidence, what we say is enabling and supportive of individuals, and rather than pushing them further. So even though some of it could be seen as, oh, this is idealistic, but you don't have all the options to do this everywhere. What we're trying to do here is to set the language and the framework and the kind of recommendations that we to continue to build upon it, so that people who may feel abandoned by the health system, by their families, by society, also have additional options to care for themselves, but to be cared by the facility and health workers as well. Because one of the other areas that we're working on, and that I didn't mention, is competency-based training for health workers. So what would be the competencies that health workers would need, and health workers writ large, so clinicians and nurses and midwives and community health workers. So what kind of competencies would they need to promote self-care as an option, promote some of these options and trust the individuals to be able to use some of these products, but also show them how to use it. What would be some of those competencies to ensure that people feel supported and respected in their use? But yeah, so maybe I'll stop there. I can continue. I think I covered some of the points. Yeah.
Thank you, Manjulaa. That's great. You did, and you actually covered some of the questions coming in, I think, as well, which is about really helping to ensure people can maintain this sense of self-determination and informed choice, and not that there's a kind of additional pressure that people should be doing all these other things rather than going to a health facility. So I think that coming back to what's the role of health workers, of the health system, in setting self-care interventions up as an additional option, but not a replacement, not saying, look, we're done, you have to do this on your own now. And that, I think that raises another interesting question, which is something that you talked about. We've always thought about the potential of self-care interventions to help reduce some burden on the health facility, right? So it's partly about bringing stuff closer to people, making interventions more accessible, but it's also like lightening a load of systems that we know are overloaded. But when we think about reaching those hardest to reach, so whether it's trans populations who may not trust the health system, whether it's people with a low educational, low literacy or low health literacy level, to really provide them the quality information in a way that's accessible to them to enable informed choice, may actually require more of the health system than currently, particularly up front, right? That might change over time. And so I'd love to hear your thoughts on that tension and how you think about that moving forward, so that self-care doesn't become another option for the people who can afford it, but that it really is doing what the guideline is always intended to do, like you said, start out to reach those who are hardest to reach at the moment.
That's an easy question. Let's see. So, most of WHO guidance is about, low and middle income countries or poor resource settings. And one of the things we found was that this guideline was actually relevant to all of the resource settings. It was relevant for high income settings as well as, other settings. And the reason for that is within even high income settings, you've got populations who have some of the worst health outcomes. I'm thinking, for instance, indigenous populations in some, high income countries who, are not able to either access services or get quality care or face discrimination. And we acknowledged upfront that we couldn't just be focusing on sort of, poor resource settings. And so some of the recommendations, yes, are relevant for people who can afford them, who can understand them, who can use them, and that needs to happen. That needs to be there. But right now, in terms of when we were getting some feedback from countries on implementation of the guideline, because COVID has made it a priority for some countries to start rolling this out. Because, as you say, their health system is overloaded or overburdened, and they just simply they need to find other solutions to be able to continue to maintain essential health services. And so, countries like Nigeria and Ethiopia, Morocco, and others are already developing their national guidance on self-care interventions. And what we're seeing there, and from some of the dissemination implementation stories, are that even those people who are who normally would not have accessed a health facility, or who normally would not have gone in to even their community health workers, or who didn't have trust with the health system, are finding these interventions not only useful, but important for their own well-being. That's what we're hearing from at least the 2 or 3. There's more, some examples that we're hearing from countries. So I think that, yes, there is still that tension, and we have to make sure that we're not burdening people, but we need to continue to provide the options and hear from the end users themselves. And so the series of sort of focus group discussions that we're doing with some of those communities that are hardest to reach. We have sort of truck drivers in India, for instance, or sex workers in Kenya. We have indigenous women in Canada and others. So really some really more vulnerable members of communities, and hearing from them, are these interventions useful? Is the approach that we're using something that you find would be helpful? And what we're hearing thus far is that the answer is yes, and that they do want other options. And while the health systems get strengthened, we know that the health system needs to get, it has to be strengthened. It's not going to happen anytime soon in many of these settings. So while that happens, these options do feel like a good option to many of these, even the most marginalized individuals. But there's far more needs to be done. I don't want to absolutely give the notion that we've done the guideline and now our job's done. So we're far, far from that. This is just a start of a conversation that we hope to continue to build on, and we hope that it will be taken into account to improve healthcare overall. Yeah.
Fantastic, Manjin. And obviously that makes sense. And, as you know better than anybody else here, the challenge of developing a guideline that's global, that can be used for everyone everywhere. And I think that the process of operationalization is so important, and that you're doing focus group discussions now to get some feedback on that, I think is wonderful, and will just help strengthen the work moving forward. I'm under no illusions that your work is done now that the guideline is complete. I'm sure that you're busier than ever. but I think it's really positive to see things moving from paper to practice and really learning from that. I would like to offer Peter and Yaniv a chance for any final comments. I know we're running low on time, but Peter, Yaniv, any final questions or comments that you would like to add?
Just make one comment as a physician who has my own interaction with my patients' self-care. I keep thinking, especially in some healthcare settings, how much self-care actually results in more need for healthcare instead of less, or I should say more focused. I think that's definitely the case in places like Southern California, where I live, where the patients most practicing self-care are the ones who have the most means and are collecting information about themselves, their children, and then they need to interact with the medical system to know what to do with that information. And so you can see how sort of self-care, if not done right, doesn't necessarily make the best use of the already limited healthcare resources. Those are significantly different issues in marginalized communities. But it is just something when I think about a resource that's limited, healthcare workers, if sort of asking for more will tax the system instead of help patients. I don't really believe that it's not the right thing to do. I do believe self-care done right will help people who are marginalized. It's just something that I think we need to be a little intentional about.
Thank you, Peter.
I will just quickly say thanks again. For me, one thing I would just add to the conversation to consider is whether there can be self-care beyond the individual. In a sense, this is picking up from a question in the Q&A, whether it could be self-care in groups, in other kinds of units, rather than always thinking about a self-contained person, to think also about a person in relation to several others who might be able to provide support, especially at different moments in life course or under different conditions. That's my last thought, and thanks again so much for the presentation, the conversation.
Thank you, Peter and Yaniv, for final thoughts, and thank you, Manjulaa. And I wish we had another hour, but I'm really aware of the time. I do want to flag one thing that you said, which was about the need for more research about this, and I really am thinking about the role of universities such as USC in helping provide the evidence base to help inform guidelines such as this, future iterations of this guideline. And I think that there's an important synergy here between what organizations like USC can do, and obviously the role that WHO plays and other civil society organizations as well. And so it feels like bringing together these diverse groups is a very useful way of forwarding the conversation. And so many thanks to Manjulaa for coming today, for sharing all that wisdom and stimulating this conversation. Very grateful, Manjulaa, that you could do that.
Thanks both to you, to Sophia as well, and Yaniv and Peter's great to meet you, and to all the participants. Thank you.